when I was trained in UK. And I think I was privileged enough when I was the president of the Perinatal Society of Sri Lanka last year. I was able to initiate a national level program, and I coined the term introduction of novel therapy to Sri Lanka. Under that, to introduce cooling and nitric oxide therapy to Sri Lanka, because all of us know when the babies have perinatal hypoxia, some of the sequel is development of cerebral palsy. And when they aspirated meconium, they develop persistent pulmonary hypertension of the newborn. So that's in that nitric oxide helps. So in those situations, we can salvage and we can modify the outcomes. So I felt it's a timely need to bridge the gap between West and the East. It is our duty as the national level leaders to bring these bigger projects to Sri Lanka to develop equity and equality and equal access to care irrespective of their income, which is known as universal health, to establish those principles in Sri Lanka. And that is one thing I always pursue. So concentrating on the this topic, therapeutic hypothermia, the key areas we want to concentrate is the criteria for cooling outside trial guidelines and contraindications for cooling, clinical assessment, amplitude integrated AEG assessment. And when we cool babies, they develop some of the complications, ventilation, cardiovascular support, and these areas, they develop complications. So better to know something about it. So these are the machines which we have introduced to 15 hospitals, which has level 3 care for newborns, sick newborns. And in the extended program in near future, that is probably within the next 6 months, another 6 machines will be introduced to another key areas. We felt like better to introduce to these areas like Nuvarelia, Hambantota, Polonnaruwa, to balance the map geographically. So the transfer time looking at and then the distances, we felt that that is the fair play. So this machine is known as a cooling machine or the therapeutic hypothermia machine. At the machine, and we named it workstation because when we are buying, we were keen to couple AEG machine also, amplitude integrated EEG. So this shows the AEG machine, and this is the smaller machine for the tachotherm to bring the temperature down to 33 centigrade, and this is the stand, and we have connection and all these wires. And this is how we wrap the baby, because we can cool certain part of the body, or we can cool the whole body. So in this process, we are cooling the whole body, which is the current practice. So when we talk about neonatal encephalopathy, it has an incidence of 1 to 3.5 per 1,000 births. So we know the birth in Sri Lanka is around 335,000 birth per year, annum. And then if we work out 1 to 3.5, we are looking at 3,000, 4,000 number. Out of that, I think around 1/3 will be where they will have significant hypoxic ischemic encephalopathy, where we have to support. When I talk like this, one of the key areas we are concentrating is developing a mechanism to gather data, because this data belongs to UK or the European countries. We do not have proper databases to analyze. That's a shortcoming, and this is another key area we have to address. But the future is to make decision based on data. And out of this group, risk of severe handicap in moderate to severe HIE occurs in 25 to 75% respectively. And they have the motor impairments and lower cognition scores. When we look at the Toby research trial, and I took it from one of the publication which I have read in New England Journal of Medicine, and then these are the publications they have highlighted when we were in UK, because a few times I visit UK regularly, and my personal view is we had to be always updated with our knowledge, and we must have a cutting edge knowledge. Unless what we teach our trainees is far from what is practicing. So background, they wanted to cool babies and look at the neurological outcomes. And what the method they did was they brought the temperature to 33.5, and this temperature was kept for 72 hours in the intensive care setting, and then the babies were warm over next 12 hours, 0.5 centigrade power, and then they looked at followed up this cohort and look at the outcomes clinically. One thing is like cerebral palsy, and look at the other neuro disability. They felt like mortality was not changed much, but the survival outcomes were good. So in this study, 494 patients were recruited, and then 163 were ultimately remain in the cool down, and 162 were opted out for not to cool. And these are some of the criteria I will later describe. The APGAR score is a very important one when we look at it, and then it should be less than 5 at the across 10 minutes. You can see the APGAR scores at the right when they selected these patients, and these babies needed resuscitation around 10 minutes also. And then they had clinical evidence of seizures, and they were appropriately cooled, and EEG shows moderate to severe cerebral involvement. And when you look at the cool group, when we look at the temperatures of all the babies who have been cooled and non-cooled, you can see the cooling temperatures for the cool babies were around 33.5, this line. And then this is the phase which shows they were rewarmed. And then there aren't any scattered distribution away from these areas. So the not cool babies, the temperature lies around 37. So this shows the cohort. One of the significant difference were the temperature levels. And then when we look at the main neurological development outcomes, p-value to be significant, it should be less than 0.05. Look at these numbers. Cerebral palsy, it's 0.03, right? Cool group 33 developed out of 120. 48 had cerebral palsy in 170. Some of the numbers are very cool, like no abnormalities, 0.06, etc. And then one of the other problems were like associated issues, because when we cool babies, all of us know we are mammals. The characteristic feature of mammals is their temperatures remain constant. So the operational system happens around appropriate temperature. So if there's any change in temperature, one example is digestion will be impaired, because enzymes work at an appropriate optimum temperature level. So is the other cellular mechanisms. So if you change the temperature parallel to that, we expect changes in all other organs. So the one example is cardiovascular system, there may be hypertension. Protein system, there will be prolonged coagulation. And then hematology, thrombocytopenia, drop in platelets. The hemorrhages can happen because of the clotting issues. There will be pulmonary issues, and then gut necrotized enterocardium, they are more prone for that. all of us know it's common in preterm, but it can happen in these babies. And they develop cardiac sepsis. And sepsis also commonly happen in the latter part of the cooling. So these were observed, and the conclusions they said was hypothermia for 72 hours there is no significant reduction in the combined rate of death or severe disability, but resulted in improved neurological outcome. Because when it is very severe, we can't do much. But in that group where the babies are being moderately affected, outcomes were good. So, I think better to know about these studies, because nowadays when we talk about some of the issues, we look at studies and the trials, and then so the two important trials were done and UK total body cooling trial and child health and human development trial done by National Institute of US. So both showed improved outcome in survivors. So this is what happened when the baby is having hypoxic ischemic insult in perinatal hypoxia. It may be abruption, it may be or the sudden collapse of a newborn baby. Whatever, failure of ATP-dependent sodium-potassium pump promote sodium influx. And so derailment ultimately result in, here it shows open, it promote entry of calcium into cells. So when calcium enters, it's one of the major player, and it promote cell death. What is cell death? Cell death is apoptosis. And now parallel to this, this is the lack of oxygen. Lack of oxygen results in apoptosis. Now another finding is when the babies are born, when they have this perinatal hypoxia, we try to give a lot of oxygen when we are resuscitating. Better to resuscitate with a low level of oxygen, because some of the studies have shown when we give a lot of oxygen, the oxygen radicals promote again the cell death by destroying mitochondria. So both terms, lack of oxygen, and when the tissues are lack of oxygen, and then secondary overloaded with oxygen-free radicals, there is again another wave of damage. So you have to be mindful about that and these mechanisms. Then when we cooled, it's very important to know about the stage of the hypoxic ischemic encephalopathy. So there are different, the one is Thomson, modified this staging system. Other one is Sarnath and Sana, which they developed a system in 1976. And this is also popular, especially in the Asian countries also. They look at some of the parameters, that is level of consciousness, spontaneous activity, posture tone, and primitive reflexes and the autonomic system. Then they look at some of the features and they categorize encephalopathy into mild, moderate, and severe. And then this for you to be able to categorize them under these areas is very important, because when we gather data, we want to see it initially when we start, what was the HI, hypoxic ischemic encephalopathy category they belong to, against it, what were the outcome later. So because we have already established national registers, we launch it with the rolling out of this program, and the national registers gather this data at a central level, and we will be able to look at it, because it's very important to look at the cost effectiveness of these programs as well as the impact these programs may make in Sri Lanka. And when we look at the criteria, there are 3 boxes. The first box is, when we cooled, can we cool preterm or term? So based on the guideline, we go for more than 36 weeks. That is near term. And then they must have at least one of the following features. That is, APGAR score should be less than 5 at 10 weeks or after birth and continued need of resuscitation, including endotracheal mask ventilation at 10 minutes. Acidosis, if you do the blood gas, pH less than 7, base division more than 16. If you have one of these features, it fulfills the first box. And this baby's evaluation, the cord blood, should be done within the first 60 minutes. Then, once the infant meet criteria A, we move to the criteria B. The criteria B is should be done by a trained person, categorization, and then staging. A moderate to severe encephalopathy consists of altered state of consciousness. That is what we are looking at. We look at lethargy, stupor, coma. And they must have at least one of the following: hypertonia, abnormal reflexes, absent or weak suck, or clinical seizures. So once they fulfill A and B criteria, they move to the C box, C criteria. That is, if you have AEG, and then they must have one of the following: normal background with some seizure activity, moderate abnormal activity, suppressed activity, continuous seizure. So when they fulfill these criteria, we cool. But what you have to remember is, luckily we were able to procure EEG machines, AEG machines. So even if you do not have, if the babies fulfill criteria of A and B, they can be cool. They can be cool. But in our Sri Lankan situation, we should not have issue, because at the onset, at the start of the program, you have the AEG machines. And cooling outside trial guidelines, because at the beginning of this year, I had a discussion when I was in UK for a short period. I had a discussion with the Oxford teams as well as the West Midland group, who are pioneers, actually pioneers as well as the leading people in this cooling. And then they said that it was beneficial to cool babies who are preterm, that is 33 weeks plus, and then criteria A and B fulfill, but it is not within the first 6 hours, but second 6 hours, as well as acute postnatal collapse. All of us know, because of some of the cardiac issues, like if you have a intracardiac TAPPD, total anomalous pulmonary venous drainage, and these babies can collapse with the closure of the duct. So acute postnatal collapse is one of the things. And then if the baby is having prolonged or the recurrent seizures within the first 12 hours of birth, that's another criteria, as well as when the baby is fulfilled criteria A but only partially fulfilled criteria B. They felt like this borderline group also benefited. We are waiting for the research outcome in these babies, but whatever the smaller studies have done, they show promising outcomes. So one of the argument against it is because they had a less severity and encephalopathy staging were lesser, and then they felt like anyway these babies will do well. For the time being, the discussion outcomes were, if you have any concern, give the benefit of doubt to the baby and cool. What are the contraindications? If there's a significant hemorrhage or thrombosis, we say bilateral grade 4 ventricular hemorrhage, and I think that is one of the criteria to withdraw care. I think, do we have to cool? I don't think we have to. And then significant dysmorphism and significant blood loss, severe PPH chain. Those are the criteria where you should not cool. And technical assessment is important. Already we talked about it. So you have to look at basic parameters, the monitoring intensive care parameters like heart rate, saturation, pre-ductal, post-ductal sets, and other things. And please do the invasive blood pressure monitoring. That is very important. And then examine these babies whether they have some other anomalies. And then from the neurological point of view, do the staging for hypoxic ischemic encephalopathy. So the initial assessment is very important, and then later you have to do 2-3 assessments, because sometimes you may not feel like this baby should undergo therapeutic hypothermia, but later you may agree for that. So better to establish several examinations. So Amplitude AEG is known as cerebral function monitors. Here can be used for this, and it may be single or dual channel. Here we use the dual channel, and then the because when we record, we look at uh, the difference between voltage gated neurological transmission between surface of the cerebral hemispheres and the hypothalamic area. The significant importance of this is when we look at the surface and this difference. The vulnerable areas are the hypothalamus and the caudate nucleus and surrounding, because there is a watershed areas where the blood circulation comes from different blood vessels. So these areas are very vulnerable, and then the difference is what we use for AEG assessment, and then rewarming phase also you may have to record it. So the one other important thing is when you note seizures, because seizures can be convulsing and non-convulsing. So especially AEG helps to detect non-convulsing seizures, and then make sure you get because these machines, I'm not sure we have the Bluetooth mechanism, but you may be able to get a recordings can be saved. It can be copied to a flash drive, and then you may be able to print it. So please be kind enough to paste one of the printouts, because it's evident that baby had these changes, number one, and medical legal point of view also, because cooling carries side effects. If baby succumb to these causes, and then if the result is the death, the patient may medical legally they may go to courts. If they go to courts, this is one good proof to show that you went through the guidelines and you did the best possible thing for the baby. And this is a normal age you can see, and the normal age top half go to microvolts around 10, and bottom half around 5 usually. And this is a normal healthy baby, and there are certain changes which changes with during the sleep, during the wake and the sleep times. And then these are abnormal EEGs. You can see the upper margin is greater than 10 microvolts, and the lower margin less than 5 microvolts. So when the seizures comes, the positivity goes up. And here you can see the burst suppression because of the seizures. Time the significant seizures push these traces very high, and then it drops to bottom, and then it looks like very brief burst. So we call it burst suppression. This is one of the machines we had because before rolling out, we had a old machine, which was used for 1 year, like, and then that was the only machine we had in Sri Lanka. And this is one of the babies being cooled. What we have brought is different, but we use the resuscitator, where we keep the babies on the resuscitator, and then you can see the ventilator, you can see all the things, and infusion pumps, and other thing is continuous nursing observation is very important. You look at this X-ray. When we cool babies, we need few things, and usually these babies are tube. You can see the ET tube. Please make sure that you note the position of the ET tube. And we need the long lines. What are the central lines usually available? UAC and the UEC. If the UAC is not possible, we can use a radial artery for blood pressure measurements. So the blood pressure measurements are very important, invasive blood pressure, because it's more accurate. And UVC, and position of these long lines you can measure. And other thing is NG tube would be there, but you can see in the middle part there is a probe because with this machine we have supplied the probes. It can be used as rectal or the per rectal or per esophageal, and then the esophageal would be fine because it is not very costly because it's 2,500 like the cost is, but it can be reused. It can be reused for a few times. So note the position of it. What I want to show is this chest X-ray of the whole body is very useful to detect various things. And then we'll move on to the key areas, system by system. Ventilation. So ventilation, if we talk about, oxygen hemoglobin dissociation curve. What happens is with the increased pH, reduced DPG, reduced temperature, it's moved to the left, and then change the other way around, it moves to the right. So when it moves to the left side, the important thing is the oxygen release is less. So although we ventilate the babies, we optimize the oxygen available for the tissue, the release will be also less. Then double burn because perinatal hypoxia on machines. Sometimes there would be some issues with the machine, and then because of the temperature, the oxygen won't be released. So all in all, the availability for oxygen at the cellular level will be less. So we have to make sure the demand is less. How do we make the demand less? We ventilate so that we support. That's one. And the second thing is we make the baby very sedated. The movement will be less. Basal metabolic rate will keep at a very low level. And if baby struggles, bolus dose of paralysis we can give. And we have to use the measurements, outcomes of the blood gases to set up the ventilation and certain changes. And when we handle the blood gas machine, please make sure you, because it's standardized for a certain temperature, body temperature, 37, make sure you your input, you change the temperature as 33 or 33.5. The ventilator gases should be warmed and humidified. Some of these things very important. And cardiovascular support, we use invasive blood pressure. But one important factor is when we cool, usually the hypothermia make the heart beat slower and bradycardia. So usually the heart rate is around 80 to 100. So if these babies have a heart rate of 120, that is tachycardia. In normal circumstances, you won't call tachycardia. And you must make sure the baby is not distressed, not hypervolemic, the blood pressure is not low, and the baby is not having seizures. These are some of the causes for bradycardia. And aim to keep blood pressure more than 45. All of us know the standard blood pressure, what we want is around which is parallel to the gestational age. If it is 36, 36, 32, 32. So here, the term is 40, around 40. Term, by definition, is 37 to 42. If you take the 42, so, but if you take it as 40, add 5. So 45 would be safer. When you give boluses, be careful because fluid overload is another issue because renal impairment. And fluid and electrolyte, very challenging. Start with the 40, 60 lower dose. What for SIH? And sometimes maybe dilution. Baby may have dilutional hyponatremia. Other thing, baby may have oliguria because of the hypoxic insult and poor kidney functions. They can have AKI, that is acute kidney injury. And then other way around, if the latter part, they can have the diuresis because of the, when we go into chronic renal failure or recovery phase, they can have diuresis. And remember the dosage of drugs. If there are evidence of nephrotoxicity, you have to, if there's evidence of impairment of the kidneys, please make sure that you are not using nephrotoxic drugs and then use the renal doses. And make the child normoglycemic, keep the glucose above 2.6. So be mindful about these things. Analgesic and sedatives we talked about. It's very important. Stress may have adverse effect on active stage infants, and it influences the therapeutic effects of hypothermia. We talked about signs of distress, heart rate, etc. And how do you sedate? Sedate with morphine. When you start when you give morphine, just think whether you have to use 10 or 20. If it is not adequate, you can use midazolam, and then the infusion rate maybe 1 mics per kg per minute to around 6 to 10, and then balance it. Our preference is the morphine, and then the midazolam will help to control the convulsions also. Gastrointestinal, and because ischemic gut, the function also impaired. You have to be careful about it. And some of the drugs like morphine, midazolam, and phenobarbital, they accumulate in liver when the baby has impairment of function in the liver. Seizures, AEG helps to detect seizures, non-convulsive seizures, and convulsive seizures you can observe, and seizures when they are prolonged, more than 3 minutes, or frequent, more than 3 per hour, consider treating. And all of us know now against phenobarbital. Now, levetiracetam is one of the drugs because side effects are less at the forefront. IV and the oral form both are available. Preferable IV because because of the malfunction of the gut. The oral oral preparation would be difficult to give, and so use levetiracetam at the first or second line. And then the midazolam, as we said, it has a sedative effect we use. Other one is phenytoin. Other one is phenobarbital. So those are some of the medication we use. Make sure the baby's seizures are under control. And if you feel like baby is not responding, think about pyridoxine. One of the questions you must ask from the mother is whether the mother felt increased activity of the baby during the pregnancy, because the baby would have had convulsions in utero. So the time mother feels suddenly baby is silent, sometimes baby is very active, struggling. So whether mother experienced this type of phenomena. And coagulation, it's as I told earlier, it affects the baby, the bleeding tendency. Look for bleeding tendency when you put tubes and when you try to anchor them. You will feel like you may observe there is bleeding, there are bleeding points, or when you put the tubes, it would have damage. This sometimes when you hit the mucosal areas, you may observe excessive bleeding. So detect coagulation, giving FFP is the answer for that. When we talk about infection is very important. What you observe in hypothermia is drop in white cell count, and through the drop in platelet. Not only platelet drops, the activity of the platelet would be also impaired. So thrombocythemia is another one thing you will observe. So with that CRP rise, and when the babies undergo therapeutic hypothermia, it may be not a good indicator. And the late rise in CRP, other thing is signify late onset sepsis, which is that is what we have observed in the babies. That's what the literature also talk about. One of the research key area we try to find out in future is whether the organism we observe in Asian countries, our country, whether these organisms are different from what people have observed already in developed countries. Avoid aminoglycoside because of the renal toxicity, and strict infection control is very important. Fundamental thing is hand washing when you handle the monitors, when you change the knobs in the ventilators. Please make sure you use the alcohol rub, and when you have come contact with body fluids, please wash your hands. Sometimes you move to touch the phone or the keyboards, computer keyboards or the files. You may return to the baby again, then use the alcohol rub again. That's called social hand washing. It's very important because these babies are very sick and easily they get infection. And the skin, as you know, when we drop the temperature, these babies can develop subcutaneous fat necrosis. Look for induration and redness, especially run your hand underneath. You may feel palpable nodules. So the position is important. When you position, keep the head in alignment with the spine. Why? Because when the baby rotates to a side, the blood supply, the kinking of the vessels in the neck region reduce the blood supply to the brain. It is plus it will be added effect on already impaired blood flow in the brain. So make sure your position is fine. Don't allow the head to rotate more than either side 30 degrees. Investigations wise, we need cranial ultrasound within 12 hours. It is less sensitive than MRI. MRI should be done within 5 to 15 days. That's the best way to assess the effect of the on the baby. And as I mentioned earlier, vulnerable areas are the thalamus, basal ganglia, and the posterior limb of the internal capsule. These are the areas where you see the changes. We use the T1 and T2 weighted MRI to look at it. And MRI spectroscopy, magnetic resonance spectroscopy is another one, because N-acetylglutamine is another one, which will tag to this tagged, and the radio the contrast would be given when we do the MRIs. It's done in developed countries. Look at this MRI. This is first one. A is the T1 weighted, B is the T2 weighted. That's why the color difference. The T1, T2, the color differences are due to the liquid phase and the solid phase. And you can see where the arrows lie, and then that shows a hemorrhage of the right ventricles. And this is a series. So ABC belong to the T1 weighted MRI, DF belong to the T2 weighted MRI. Look at where the arrows lie. It shows the changes. So the documentation of these changes are very important. Radiologists can help in this. And moving to something like slightly different. Now, all of you know, we want to establish neonatal transport network. That is the way forward. But there are some issues of the when it operational, the way it operates. But forgetting that, we must be able to cool these babies if we are inside these ambulances. So I think when I bought these things to train the trainees on this concept, I have ordered one machine to one of the ambulances in Castle Street. I was able to get an ambulance from the Ministry of Health, and then we want to equip this with cooling machine to train our trainees, because when they go abroad, they will see these concepts and they are very familiar with that. And then nursing care is very important. One of the most important thing is open and honest communication, because these babies can die. Tell the truth to the parents, but in a more subtle way, without hurting their feelings. And then you need training for additional training for these nurses. Make sure they are knowledgeable enough. We'll develop a program, separate one for the nurses, separate one for the doctors, to make sure that they are very knowledgeable about it. And clear documentation and use of the checklist is one way of identifying these things, their deficiencies. And prognostication. The prognosis can change with the time. And it's very important to look at their condition, neurological examination, the outcomes in the EEG and the MRI, and then discuss parents with a timely manner. Don't delay it. And whatever you discuss, please kind enough to document. And those points are very important medical legally. And with these discussions, sometimes we have to reorientate the care. Although we try to salvage their lives, later we may move in the palliative pathway, because if the baby develops bilateral grade 4 ventricular hemorrhages, so it's very important to discuss with the parents palliation. And then if you have doubts, just wait for 1 or 2 days, that's 48 hours, before coming to a very concrete decisions. And then you can discuss with the parents also about these things. And then if you are a junior or middle grade doctor, you can get the help of the consultant. Better for the consultants to involved in this decision. What I want to tell the trainees is now UK and other European countries have moved in a different direction. Early it was consultant-led care. Now it is moved to consultant-delivered care. So this concept is very important. And then make sure that when you're interpreting some of the readings, especially age, the babies may be on anticonvulsants because anticonvulsants changes even the outcomes of the readings. That's one. And then the number two, when we assess the brain function also for withdrawal of care, one thing is we have to consider the medication baby's on. And finally, this is a chart we want to show. These are the social emotional growth chart. This is one of the babies. What I highlighted here was that when we follow up these babies, they may have subtle neurological impairment. They need early neurorehabilitation. This is another key area one day I want to talk about, and neurologists do a better job here. And then because when we do some intervention, we have to provide follow-up care also, and then these babies should be initially will be followed up at neonatal clinics, later will be followed up at maybe pediatric clinics, and then their assessment of the growth is very important. And this growth, when I talk about, I want to talk a little about, and then motor impairments are the commoner. Motor, gross and fine, and then there may be speech effects, speech and language, and because they are receptive, and comprehension. Other thing is articulation in another area. Then the cognition, another key area we have to know, and the social development also may be impaired. And they may have cerebral palsy. So the support we give to the parents and the children are very important. And then there are a lot of other lateral issues, lateral themes, where we can talk and in a later date. With that note, I think I will end my presentation. Thank you.